Good morning, everybody. We're going to give everybody just a minute or so to get situated in our Zoom room here. All right, just a couple more minutes while people are getting admitted. Wonderful. We're going to get started. I know there's a few people still popping in on the Zoom call. We are so excited to see everybody today for the Healthy Behavior Optimization for Michigan CQI Tobacco Cessation Summer Collaborative Meeting. We're going to be together just for a little bit over an hour. And I want to start by just introducing our amazing team. My name is Tammy Chang. I'm the director of HBOM. We have Tom Casino here, who's leading our physical activity initiative. Tom is a cardiologist. We have our amazing program manager, Ann Maringer, Marika Wasilewski, our project manager, Sarah Gunn, our administrator, Laria Young, and Noah Kim, who are our design team, Ryan Karpus, Mick Zolikoff, and our informatics team, who work together with Laria and Noah, and Fred, our mascot. So we are all here today, and we're very excited that so many of you have joined us today. We know that some of you are new to our collaborative meetings, and some of you have been here before. So we just want to review that the goal of this meeting is threefold. We want to connect with you, and also for you to have an opportunity to connect with others who might be doing the same type of initiatives or might have solutions that may answer some of the questions that you have. We also want to provide access to resources, many of them which are new, and our design team will be presenting a little bit more today, and also to share some rosebuds and thorns, some great stories and some challenges. So a quick review of our meeting agenda. I'm going to do just a couple more minutes of a welcome. Then we'll spend some time with Dr. Alicia Lucier. She's a surgical resident from the University of Michigan who will be talking about leveraging surgical care to impact population health. Then we'll turn the mic over to Laria Young and Noah Kim from our design team to give some updates on exciting new tobacco cessation resources that we hope you all can take advantage of. Then we want to take some time to address these questions that many of you have submitted in the registration with some breakout room discussions so we can get deep into the details. Then we'll spend just a few minutes introducing what I call a sneak peek into one of our new initiatives on healthy eating with Marika Wasilewski, and then we'll conclude. So we want to start always with just a description of what HBOM is, Healthy Behavior Optimization for Michigan. We are a quality collaborative initiative, and our goal is to make the healthy choice or healthy behaviors the easy choice. And we need and want to work together with you. It takes all of us to make these types of changes. So one of the things that we do is focus on times when people are very motivated for change. We call them teachable moments. And a lot of times these teachable moments happen during major health events. For example, before, during, after a surgery, around the time of diagnosis of a major chronic condition, and during pregnancy. So we know that those are times when people are wanting to make health behavior changes, and we want to make sure that we're connecting them with the resources that they need and want to make those changes. HBOM is a partnering CQI, so different than other CQIs who may have their own constituent physician organizations or hospitals. You might be from one of those. HBOM is a partnering CQI, which means we work with other CQIs to create and implement healthy behavior quality improvement projects. The three areas we focus on are tobacco cessation, which we're going to talk about today, healthy diet, and physical activity during those teachable moments. We're so proud and excited that we have this many tobacco VBR partners. They range from emergency medicine to bariatric surgery to MSQC urology, some wonderful, wonderful partners doing great work, and we're excited that you all are here today. We cannot talk about tobacco without talking about the why. Why do we focus on tobacco? You've heard us say it again and again, tobacco is the single greatest preventable cause of disease and premature death in America today. It's a challenging problem. It's a challenging issue that takes lots of people coming from all different directions. And it's also a very high value health issue to work on. And one of the things that we know is that tobacco users, smokers, many of them, up to 70% or more, want to quit. But using MVC data, we've seen that only about 15% of smokers in Michigan receive treatment. And that's a really big gap. And we know that we can do better. And that's why we're here today to talk about some of these resources and talk about some of these programs that we can help you and people across the state to implement. I like to talk a little bit about one of the most common questions or issues that we hear about, which is for providers, how can I fit smoking cessation into my busy workflow? This is a real challenge. And one of the things we like to remind people is that it can only just take a few minutes to manage this and to talk about it. You could say the sentence, as your provider, one of the best things you can do for your health is to quit smoking. Are you interested? And if that person is interested, appropriate and wonderful treatment would be to refer them to the Michigan Tobacco Quit Line, 1-800-QUIT-NOW. They are a comprehensive quit line that we'll talk a little bit more about and that we hope that people across the state will use more. Or you could provide educational resources and materials. Some people may have in-house tobacco cessation services. All of those things would be wonderful resources to spread and use across your systems, organizations, and practices. So we cannot say enough about what the MDHHS Michigan Tobacco Quit Line does. It's a comprehensive program that's statewide, open 7 days a week. And there's phone and online counseling that includes email or text. They can mail nicotine replacement to your patients. There's self-help educational materials, online communities, and they refer to local programs that are specialized for different communities. And they also have counseling available in many different languages, including Arabic, Spanish, as well as English. So please know that if you have patients or providers looking for resources for patients, 1-800-QUIT-NOW is our most highly recommended resource. So with that, I'm very excited to turn the mic over to Dr. Alicia Lucier. Alicia is a fifth-year resident in surgery at the University of Michigan, Michigan Medicine, and we're really excited because Alicia and her team are doing some amazing work leveraging surgical care to impact population health. So let me turn the mic over to Alicia.
Hi, everyone. Do I have control over the slides?
If you go to the top of the screen under View Options, and then you can request control.
All right. Let me see. Do I use the, oh, perfect. Okay, let me just back up. Awesome. Well, I'm just going to get started. Thanks, everyone, for this opportunity to present. I am super excited to be tackling smoking cessation with you all today. And I'll be sharing a growing pilot program that we've implemented in our pre-op clinic at the University of Michigan. I'd love it if this presentation was informal, so really feel free to interrupt at any time. So I'll start by sharing the motivation behind our work, and then I'll get into the details of our pilot program and then just quickly end the presentation with some future directions. Our project was motivated by a few factors, the first of which was a study that we did looking at predicted complication rates after elective colectomy using the MSQC database. We showed that a highly comorbid patient who undergoes an operation by a high-performing surgeon at a high-performing hospital has a predicted complication rate of 66%. And this same patient would have an even higher complication rate if instead treated by a low-performing surgeon and hospital. But in contrast, a non-comorbid patient treated by a high-performing surgeon and hospital only had a predicted complication rate of 1.5%, and this only went up to about 6% under the care of a low-performing surgeon at a low-performing hospital. So put it simply, patients who have poor foundational health have bad outcomes, and to have future impact and affect population health, QI needs to focus on interventions that target poor health behaviors at the patient level, as these, along with the social determinants of health, are really the main drivers of health outcomes. And then second, as Tammy had mentioned before, surgery is a teachable moment. Not only would addressing poor health behaviors improve patient foundational health, but the surgical episode is the perfect time to do it. As surgery is now increasingly recognized as a teachable moment during which patients are motivated to achieve sustained behavioral change. In particular, simply undergoing an operation has been associated with increasing smoking quit rates. And actually, one study showed that more than 50% of smokers undergoing surgery for smoking-related diseases successfully quit after their operation. Unfortunately, in its current state, the surgical episode remains under-leveraged as a teachable moment, and active smokers presenting for elective surgery is still actually quite common. In the state of Michigan, almost 1 in 4 patients smoke at the time of elective surgery, and efforts to address this are lacking. So before implementing any intervention, we sought to understand the baseline rates of smoking and what treatment options were available at our home institution. We are lucky to have a tobacco consultation service that provides virtual smoking cessation counseling for patients. This service offers on average 6 sessions with patients, 3 counseling, and then 3 to prevent relapse following a quit date, and then 3 follow-up sessions at 1, 3, and 6 months. They also evaluate patients for underlying issues and place referrals for mental health, for example, on an as-needed basis. And I realize not every institution has this, but referrals to the state quit line or other cessation intervention would be a feasible alternative. However, despite the availability of this incredible counseling program at our institution, when we looked at our general surgery patients undergoing surgery between June and September of 2020, we did find that 10% of them smoked, but we were only referring 8% of these patients to our tobacco consultation service. And when we saw this data, we saw that this was our area to capitalize. We explored the reasons behind this lack of referrals and found 3 main things. 1, there was a lack of emphasis on prioritizing smoking cessation at the time of surgery. 2, providers at our institution were just unaware that there were these really amazing pre-existing institutional resources to provide patients free of charge. And then 3, the infrastructure to inquire and remediate these issues was just absent in the surgical workflow. So in this context, we sought to design a simple screening and referral pathway. Realizing the pre-op clinic was a common touch point for many of our surgical patients, we engaged the providers who evaluate patients before surgery to discuss our goals. The physician assistants loved the idea of a simple screening and referral pathway. It was in line with their mission of optimizing patients before surgery, and they were often already collecting smoking status during their visits. However, the subsequent referral infrastructure was not in place. So we worked with the physician assistants to design a short screening and referral template that is embedded in their history and physical note templates. Engaging the physician assistants and having them lead the design of this template allowed us to make sure it fit well within their workflow. So as a part of the H&P, patients are screened for active smoking. If a patient smokes, they are advised to quit by the provider and offered a referral to TCS. And then pictured here is a screenshot of the screening and referral tool. You can ignore the top part of the grid, which documents any non-medical needs a patient might have. That's a separate quality improvement that we are running. The smoking screen is 3 short questions. 1, is the patient smoking? Yes or no? 2, if the patient is smoking, did the provider advise the patient to quit? Yes, no, or not applicable if they're a non-smoker. And 3, if the patient is a smoker, were they referred to the tobacco cessation counseling program? Again, yes, no, patient declined, or not applicable if a non-smoker. On average, this screening takes less than 2 minutes and is easily performed within the visit time. I also wanted to just briefly highlight that our 3-question screen hits the qualifiers of the MSQC value-based reimbursement. We are documenting if patients are active smokers, whether the provider advised cessation, and that treatment was offered. So after 1 year of implementation, about 18,000 patients have passed through the pre-op clinic, and almost 80% of them have been screened. Of these 14,000 patients who were screened for smoking, 12,000 screened positive for smoking. And in total, we've been able to refer 323 patients to TCS. Separately, we conducted phone surveys with patients who accepted a referral between February 8th and August 31st of last year, 2021. Of the smokers who accepted a referral to TCS, the vast majority agreed that the surgical episode was an appropriate time to address their smoking habits. And actually, almost 60% of patients were more motivated to quit than before their preoperative visit. And then most promising is that at the time of survey, over 40% of patients reported quitting smoking. That rounds out the data from our pilot Young Life. Our next goal is to increase the number of touch points during the surgical episode in which we address smoking cessation. So the idea behind this is to make every interaction with the health system count, as there's good data showing it takes multiple quit attempts to be successful, and smokers are more likely to quit with repeat interventions. So as I mentioned previously, right now we're screening in the pre-op clinic, but we are also planning to start screening and referring during the initial surgical consultation. We have partnered with a section of the University of Michigan Cancer Center that is currently using an MA or medical assistant driven workflow, where the MA, using the 3 A's, asks about smoking, advises cessation, and then assists by offering a referral to TCS for those who are interested. If the patient accepts the referral, the MA pens the order, and then the provider signs it at the end of the visit. And the MAs are alerted to do this workflow through a best practice advisory in the EMR during check-in if a patient is an active smoker. And lastly, while we're celebrating our initial success, we do acknowledge that there's a ton of room for growth and creativity to refine our quality improvement initiative. So first, as our data shows, only about a quarter of patients are accepting referrals to TCS. I really think novel strategies to connect with the other 75% may help improve rates of treatment, and if nothing else, infrastructure to follow up with these patients would be valuable. Second, of the referrals to TCS, only 2/3 of patients are actually reached by telephone to discuss the program and have an initial intake. Ultimately, of these patients who are reached, 12% opt to just do it on to attempt cessation on their own. 15% are not ready to quit or are no longer interested in the program, and about 14% actually enroll in the program. The vast majority are provided information, but lost to follow up. Identifying strategies to increase enrollment would certainly be valuable, but at the end of the day, it's also fantastic to see that a simple, short 3-question screen in clinic resulted in over 30 patients making a serious quit attempt. And these are patients who otherwise would not have pursued this critical health-changing opportunity had it not been incorporated into the surgical workflow. And I really think this highlights what stands to be gained when we use healthcare visits to make every contact count. So that's all I have. I really hope this was helpful to hear. My goal was to highlight how small changes can have big impact. And I hope that these initiatives can grow and permeate all the surgical touch points so that we really do make every contact count. I'm happy to take any questions and feedback. And thanks again for this opportunity to share our work.
Thank you so much, Alicia. We're going to take a few moments and open it up to the floor. You have given so many concrete examples of the implementation of this at your institution. And so does anybody have any questions? And maybe we'll stop share screen for now. Feel free to raise your hand. As people are thinking about their questions, I wonder if I could ask you, Alicia, one of the things that I think about is how hard it is to implement a program like this. What do you think was the hardest, what was the most difficult challenge trying to take a project like this to change all of the workflows and all the staff and team behaviors?
I think it was initially getting the buy-in from the PAs at the pre-op clinic, and not because they didn't support the same idea, but just simply because the logistics of getting everybody in the same room, getting everyone to agree on an intervention and then disseminating it can be challenging. I think the way that we approached the process was appropriate. So we started with the director of the pre-op clinic just to understand whether this is something even worth pursuing, get a general lay of the land. Then we asked her advice on who might best be willing to pump up the staff. And there were two PAs that are sort of recognized as leaders in the clinic. And so we then sought their input. And having them present this as something that they're excited about was, I think, really crucial, instead of us just being like, here's an idea we have, please do this for us. That process took a long time. You know, the 3 questions we had in maybe half an hour, but getting the whole group to sort of move forward as a whole was, I think, the most challenging part, but it was totally worth it. Like I said, we had this idea, but didn't know where it would best fit, and having that PA input on, wow, it'd be terrible if it was in this location, but if it was here, like, oh, I'm already in that spot anyway. That was so valuable. And I think it lended itself to success from the get-go, without having to do a lot of, you know, problem solving down the line.
Wonderful. That's really helpful. I wonder if anybody else has any questions about the way you've implemented this project. As people are thinking about it, I'm going to ask you another thing that came to my mind, Alicia, which is the data aspect of it. You were talking about the metrics and understanding. How does your project collect and measure?
So that has been one of the trickier parts of our project. Learning the ins and outs of my chart, I think, before implementing a solution, should we ever redo this from scratch, I think would be helpful. I think the way we went about it was good for implementation, but when you look back at trying to collect data, like how many people use the template, how many screened, getting data from a note is much more challenging than getting data from flow sheets, for example. There are workarounds using different search techniques like eMERS, which I'm not sure how available that is for everybody, but it works for our EMR.
Your EMR is Epic, right? I think a lot of people here have Epic, but the eMERS you're talking about, it's like a search tool through Epic.
Yeah. So we've had to use that, and it hasn't been perfect. And so I think while we can rely on the data, if I could do it again, I might think of a different way to make data collection easier from the start. But I think as long as there's a way to collect data, even if it's painful, it's worth just getting this in the door, getting people excited about it. And then if it needs to be changed, people are already used to it, they're expecting it. But I do wish we could do that slightly differently. That said, we have the data, it's just a little bit harder to get. I do think it's really important. And every time that we presented at a pre-op meeting, the PAs were always anxious and excited to see the data, like how well are we doing? Where can we improve? And so I think it's a really critical component of, you know, sustaining this QI initiative.
Fantastic. We have a couple questions in the chat.
Well, perfect.
Angela Medrano says, I think your utilization in the MAs was ingenious. Did they receive any training?
Yes. Let me just reiterate, though, it was totally the Cancer Center, and they piloted this in two episodes, I guess. So the first one, they trained the MAs with a slightly different workflow. But to answer your question directly, the MAs all get together. There's a PowerPoint that's shared. It contains data on why this is important for them specifically. Why is it important for cancer patients? And then there's step-by-step, screen 1, screen 2, you know, ask, advise, it's assist. And so they are also able to create a dashboard that tracks engagement with the BPA. And that was helpful because the Cancer Center later learned that they were actually having more trouble engaging providers than MAs. And so that ended up leading to a second iteration, which is now being piloted, which resulted in the BPA for the MAs and, you know, reducing the required engagement from the providers. But yes, lots of training and practice and, you know, troubleshooting, but it's been great so far. And I think they've added 5 or 6 referrals from just a small urology oncology clinic in the cancer center per month.
That's incredible.
Yeah. And providers got training too.
Can't trust those providers though, can we?
Never.
Cynthia Noack has a question. How did you track these patients? What tools did you use, i.e. spreadsheets, trackers, or build Epic reports?
So it was a combination of a couple of those. The way we would first generate our pool of patients that went through the pre-op clinic was a MyChart report. We have an awesome team member, Alex Holloway. I don't know if he's on this call, but he's super savvy with MyChart and is able to pull every patient that's gone through the pre-op clinic between a certain set of dates. Then doing that, we generate a list of MRNs, and then it's those MRNs that we then use through eMERS, which helps us search their chart for this template that we put into the note. This is where things get tricky, but that's the general workflow. We then look for the template within eMERS, and then we look for the answers within the template. I would love to streamline that more in the future. So I'm not sure what trackers are, but maybe you could.
It's a little bit like, it sounds a little bit like eMERS. And so,
Okay.
Alicia, I just wanted to clarify. So it sounds like there's a little bit of automation using Epic, but then there's some manual abstraction as well.
Yeah. Yeah. I think the way to do this eventually will be to get data in flow sheets and to create a dashboard that can just be automatically refreshed every month or 2 or 3 or whatever works for the teams. So there is a way to better automate it, but yeah, I hope that was helpful.
Yes. I think that was helpful to me to conceptualize in real time. Thank you, Cynthia, for the feedback as well. Cynthia says, yes, thank you.
Perfect.
Kathleen has a question. Can the MA training PowerPoint be shared? I like the pilot idea with urology oncology to demonstrate success.
Yeah, I'm going to just take a screenshot of your name so I don't forget to reach out to the cancer center who designed the slides. I'll just ask their permission and then send along what they have for training. And I can send along the provider education as well if they're okay with that. But I will be in contact with you and their project manager.
Fantastic. And Kathleen, if you have trouble connecting, you can always email HBOM and we will help to facilitate that as well. But thank you so much, Alicia. There's only 2 minutes left, and I want to just ask one last question, Alicia, which is, you had mentioned that the original project before, maybe for the Cancer Center, was focused on provider behaviors. And we hear time and again that it's so hard to, it can be hard to engage providers in even saying that sentence. Have you found anything that might work or that has been successful in your projects, engaging provider change, like basically changing provider behaviors?
Yeah, that's always so challenging. I think the area in which we got really lucky and identified the right partners is that the pre-op clinic used to be seen as just a history and physical factory. But recently, like even before we got started with our initiative, there's really been a push for them to be seen more as a pre-op optimization or an operative optimization clinic, not just note takers. And they really do that. They pick up things so many times that providers have missed. Things have changed for patients before surgery. Now we are focusing more on, health behaviors and trying to, again, like I said, optimize patients before surgery. And so I think this fell right in line with their mission and the true work that they do. And so I think we were able to empower them and just go along with what their identity was the whole time. So I think without that, I don't think it would have gone as well. Like we really found partners that feel like this work is one with us. And so I think that was really a key step. And then we also did have to work within their workflow. So we really emphasized, let us know if this takes more than 2 minutes, because that is not our intention. We know that they ask over 300 questions in a visit. And so this was more of a reworking and of their workflow that incorporated some of the questions they asked, but cannot overstate the fact that it's just so hard to ask people to do extra work, and it has to be more of a compromise work within the current state type solution. So I think they really appreciated that as well.
I love that. It reminds me of our team members who said at an Moxie meeting how an oncologist says that he asks because he cares. It really speaks to the identity of what providers feel like is, their purpose, which I think is so amazing. I wonder if we have time for this one last question. Did you track smoking cessation interventions in the hospital prior to the patient's discharge as well? If so, how did you track and how did you get buy-in from the surgeons to provide such counseling interventions? You may have addressed some of this, but at least that first part.
Do you mean for inpatients? Okay, so all of our work is outpatient. I should mention that our TCS service does have an inpatient component side, but we have not ventured to that side yet. That said, any outpatients that we referred who were not contacted prior to surgery do remain on an outpatient contact list and are contacted after surgery, but I don't have any insight as to the workings of the inpatient service.
Thank you so much, Alicia. We are
You're
so
welcome.
grateful for sharing this awesome project, and congratulations to you and your team for your early successes. We look forward to staying in touch and learning more from you.
Definitely.
And we will help to track those slides down. I know I've seen them and we're very impressed with both the MA and the provider set. And so we will track those down and see if we can get permission and put them into the after visit email so that people have access to them.
Perfect. Thanks, everyone.
Thank you. So now I'm going to turn it over to Laria and Noah for our next section. Laria, take it away.
All right. Thank you so much, Tammy. And thank you, Alicia, for that amazing presentation. So I'm so excited that I now have the pleasure of representing the HBOM design and informatics team to share with you some of the exciting updates we've been working on. We know how important having the right tools and resources is for this work. And this has been a core goal of ours since day one to be able to provide the best tools available to you. Go ahead and get my control to work here. There we go. All right. So before I jump into some of the new work that we've been doing over the course of this year, I wanted to quickly talk about some of the resources that we already currently offer for anyone who is new on the call today. So this is our tobacco cessation resource box. This was a tool that we created because we know that you may need a variety of tobacco cessation resources. There are many, many online, but filtering through them can be really hard. They exist on all sorts of different websites. And so we really wanted to curate a box that had all of those best resources that we believed in available for you. So if you haven't requested a box yet, you can on our website. If you visit hbomish.org and look for this button that looks like this one here up in the top menu bar, you can go ahead and request one of these for free. So let's dive in and talk about what some of the resources are in that box. By far, the one that we've received the most positive feedback on from participants is this nicotine replacement and medication guide. And so this NRT guide that you can see here on the bottom provides a really high-level visual overview of some of those nicotine replacement options, things like the patch, gum, and an inhaler, and tells a patient very simply how to use them, overall dosing, and things like that. And the medication card here is a 5x7 postcard that shows those two different tobacco cessation medication options to help a patient make decisions about which one they'd like to try if they want support in their cessation effort. And so these are things that are meant to be supplementary. The nicotine replacement guide is a tear-off pad that you can put in your clinic or office and have available to share with a patient and have a conversation very quickly. Both have spots to write notes and things like that so that they can take that information back with them in their tobacco cessation effort. And I want to highlight here, this is a question we get from a lot of people. How can I refer or connect patients to smoking cessation programs? And one of the things that we've tried really hard to do is include the information to the Michigan Tobacco Quit line that Tammy talked about earlier on each and every one of our materials. So on that resource guide and on that medication card, you'll see that we have all that information highlighted here. And we also include links and QR codes to help patients really easily access their services. So in addition to this, as part of that cessation resource box, you can request these Michigan tobacco quitline materials. So these are really focused on simply highlighting the quitline as a resource for patients. Like Tammy said, we always want to encourage providers to refer to in-house services, but we also know that a lot of health systems simply don't have those available. And that's where the quitline comes in. So we offer these cards and card holders that list out the services, again, have easy multiple ways to access online or via phone for patients. And here you can see an example of one of our posters that has the little tear off tabs at the bottom so that a patient can tear that number off if they want to take that information home with them and contact the quitline later. In addition to this, we also created this Tap to Quit NFC badge. So we designed this to be worn by a provider, either, or hung in a room, kept in a pocket, wherever is convenient for them. And this allows them to simply tap this card on a patient's phone, and it'll create a pre-populated text message. And all they need to do is hit send, and this enrolls them in an HBO text line that will send information about the quit line and other resources directly to their phone to help make that process quick and easy. Our goal here is to make providers' jobs as easy as possible. We don't want them to have to remember all of the quit line information. We don't want the patient to have to remember where they put a card or it gets lost or thrown away. And so this way they have all that information directly with them on their phone. If you could advance the slide, that'd be great. Thank you so much. So in addition to that, we also know that we're so fortunate to be able to work with partners who each have their own unique set of needs, everything from, bariatric surgery to anesthesiology. And so we wanted to create resources that had a variety of different messaging for patients and for providers that you could select to use in your office or clinic. And so this started with working actually directly with our participants to design a set of posters. And so here you can see one on the left, the original design from a participant, and then what our team was able to create with that's now available in the tobacco cessation resources box that you can request. And so here's another example of that. This is Sandy. She's our data abstractor for MSQC. And here you can see the poster that she designed there on the left, and then the version that is now available for you online if this is a poster that you feel like would be a good fit. And this process has been so rewarding for us and hopefully rewarding for our participants. This is something that we really want to continue, really want to make core to our mission, this sort of collaborative aspect. And so we wanted to share a couple words from people that we've collaborated with you.
I was so excited. I was sharing it with my boss the other day, and she's like, "That's so cool." So I'm sharing a team meeting one of these days. So we're very excited. The story of creating it was really simple. So I was tabling with Open at the MSQC conference, and I saw this organization, and I walked over and I'm chatting, and they said, "Hey, we have this poster design." And I thought, oh, this will be fun. So I grabbed the design sheet, and I remember looking at it, taking it back to my table and sitting down and thinking, okay, what would I like to see in a poster? And I'm trying to think of my recent doctor's appointments and the offices I've been on. And there's a lot of materials out there that mean well, but they stop you at the door because they use language that's unfamiliar, they use terms that aren't comfortable. And so you leave people being like, what are you trying to say? Or are you implying something about my health habits? And then you've turned people off. You've lost them because then they don't even want to have that conversation. And so I try to make things as approachable and really invite you to ask questions like, oh, hey, why'd you put that emoji on there? And then we can have a conversation about it and really open that door. So we're like, this is such a cool partnership, and to expand into fun avenues like poster design, which we never would have thought of, but this is the perfect way to cross collaborate and really leave an impact. Oh my God, it was so fun to talk about it and share with other people.
Been a nurse since 1979. I got my bachelor's degree in 1994. I have worked in peds, oncology, general surgery, ortho, OR. Right now, I abstract for Alpena, so my nursing career started in Alpena and will probably end in Alpena. I would like the fact that if we could get more posters out, more things that we can hand out just electively, that maybe we could get to somebody ahead of time. And that was kind of what my incentive was to it. It's like, let somebody think about what can happen and maybe it'll nudge them in the right direction. That's great. I'll have to contact them so they can tell them that it's someone that works for my Michigan. Yeah, sometimes it helps to have somebody local that, yeah. And as you know, the more you tell people, 3 or 4 or 5 times, the more they hear it, the more likely they are to do something. I grabbed a box for Teresa who wasn't there and shipped it to Gratiot so that we all of our CQIs that are doing MSQC have the same information. So it's system-wide. I know my general surgery patients become ortho patients. My ortho patients become general surgery patients. And I feel the more that we do across our CQIs, similar things, the more patients we'll reach.
I would encourage other CQIs to definitely collaborate with HBOM because I know that Moxie has thrown a couple different ideas of like, oh, could we do this or could you all help us with this? And they have been so collaborative and so enthusiastic to work with all of us that it's just very, very exciting to have such an energized group. We had an instance where we had to change, some of our graphics to match our Gynonc stats, and they did such a quick turnaround in the materials, and they were just like also professional looking. It was really great. It was really awesome to get to collaborate with HBOM.
Nobody can handle tobacco cessation alone. The more resources you can get, experts across the state, resources that are generated through the state and HBOM, it's such an advantage to have that. So we're not recreating the wheel. We don't feel alone in what we're doing. There's expertise because we can't do it all of the time. So it really has been a true partnership. So although this is HBOM's role is to help with tobacco cessation, they, at our meetings, at our regional meetings where they came and spent the whole time at the meeting, they would also talk about the work that we'd done. And so easy to violate dignity and plow over the work other people have done. And that was not at all what happened. And I think it made our whole team feel involved and feel respected, which is part of what we try to model ourselves. So I love that the core values and the way HBOM works with other teams honors those other teams.
So a huge thank you again to all of our partners. We cannot say enough how much we enjoy doing this collaborative process and creating these new resources with you. And we want to continue these opportunities for collaboration. And one fun way to do this is to submit a poster design. We would love to continue expanding this collection so that we have this huge variety that works for all of our different partners. So if you have an idea or something you want to see visualized as a poster or another resource, please let us know. You can email us directly at any time, or you can find a submission form here. We have a template you can download, draw, sketch, write, whatever is comfortable for you to create a poster design and submit it on this website up page here, our tobacco cessation poster page. So we're so excited about how much interest we've seen in this materials from our participants. You can see here the numbers of materials that have been requested since the beginning of this year. And a huge thank you again for everyone who's doing the hard work of actually putting these to use with patients. So we just want to highlight this here. Thank you again, and remind you that if you would like to request a box, you can do so by following the link in the chat or clicking that button in our upper level menu. And we do want to say thank you to everyone for your patience. We have a small team who works mostly remotely. So we are working as hard as possible to get these materials to you as fast as possible and are in the process of implementing a more automated system so that we can make sure that your requests get filled as quickly as possible. But once you do have these materials in hand, again, we encourage you to work with us to improve and develop new ones. That's what we're really here for, to work with you and hear your ideas. And so again, you can do this by emailing us directly, or we will send out a feedback form to you 30 days after your materials have shipped. Hopefully that'll give you time to receive them. And if you're distributing them to providers and things like that, give some time to do that. If you receive materials but haven't submitted a feedback form, you can do so after this meeting by following this link. And we'll put a link in the chat as well and in the follow-up email. So, and these are two more frequently asked questions that we get from people that I think are really valuable. So, how do I find smoking cessation programs for patients? And what low cost or free options might be available to my patients? And so to address this, we've been working really hard to create this new online resource library. And our goal for this is to curate tobacco cessation resources to make them easy for you to find and also easy for you to share. So this is what it looks like, and there'll be a link in the chat for you, but you can find this now by going to our homepage and scrolling down. You'll see it embedded there. And as of today, we have almost 100 resources up here for you. So again, our goal is, we know there are so many tobacco cessation resources out there. And while we can create our own, we also know there's so much work being done, like you heard in the video, and we really want to support and lift up other people's work as well and make those resources as available as possible. So we've gone out and found all these different resources, everything from groups and classes to apps, which was a specific request we got, and tried to find ones that we felt were the most valuable. And you can find these here in the resource library. We also know that sometimes you might need a specific tobacco cessation resource for a patient, things like if you have a pregnant patient who is smoking. And so we've tried to make these resources as easy for you to search and find the ones that are specific to your needs as possible. And once you find that right resource, this might be something that you want to email or text yourself, or email and text to a patient right during a visit, or even save as a PDF so that you can print it out. So we've built this functionality directly into the program here. And so you can see how this works. There's a share functionality on both the front and back of each of these resource cards. And all you have to do is type in your email or your phone number and hit send, and it will send you a text message or an email. You can also hit save as a PDF, and it'll generate a printable version for you. And in addition to that, I wanted to highlight a page on our website. This is the partners page. So you'll see that option up in the high level menu. And this has a few new tools that we've added. One is we've worked with partners to generate a lot of specific slides, things for surgery and oncology. And we'll be adding those up to our website so they're available to anyone, because we put a lot of work into this. And we also know that sometimes you might not have the time before a presentation to reach out and have slides developed for you. Although we always encourage you to do that. So you can find these now on our website. And we also have a download link here for our value reimbursement toolkit. So you can download that and print it, or have a digital version if you want to look up some of those smoking cessation codes, see what the gold standard is, and things like that. So with that, I'm going to pause here for discussions and questions. We'd love to take a break and hear from you, some rosebuds and thorns, things that have been successful, things that have been a struggle, or any other experiences you're having during your tobacco VBR period. So I am going to go ahead and open it up. Please feel free also to put questions in the chat if you have them, and our team will do our best to answer them.
Laria, that was amazing. I hope that our participants today will take advantage of all of these resources your team has created. And as people are typing in the chat and thinking of questions, I wonder, can you tell us, I know you mentioned the feedback form that Noah had texted out, that mishmed.org/JY92K. Like, why is that important for people to complete once they've gotten a box? Like, why should they even take a minute to do that?
Yeah, that's a great question, Tammy. And I think there are multiple answers to that. One, we really want to make sure that these resources are actually useful to you, and that they're actually getting used. So something especially like the NFC badge, this is a little bit different than a lot of the tobacco cessation resources that are out there. We developed it because we consistently heard that there was a need to be able to quick and simply refer patients to the quit line in a way that they would be able to have that information going forward. But we also know it's a little bit of a weirder technology, maybe something people aren't as comfortable with. And so we want to hear how you're using it, where you had struggles, so we continue to help with that process. And I think that goes for all of our materials. We just really want to understand how they're being used in the field so we can be as beneficial to you as possible.
Awesome. I was also going to mention, I think that what I found really useful as people have given feedback is this understanding of how many people have been impacted and the value it brings, because the resources are free right now. And so we're always trying to communicate with Blue Cross Blue Shield of Michigan and other constituents that these resources are valuable, because we tell them and we tell other people they're valuable, but it's only really when the user, when you all or the people you're giving the resources to tell us and give us the stories and tell us how they've been used. I think that that's actually the most valuable. So we're so grateful that when you receive a box, or if you're, have a minute right now, even in this meeting, you can click on that link and give us some feedback, good or bad. We love difficult feedback, because that's how we learn and grow. We really look forward to making things actually useful for people. So thank you. Do we have other questions from the field? I know we have lots and lots of people here. Are there things that are on your mind, things that you wish that you had to make your tobacco cessation work easier?
Yeah. Oh, I see Michael raising his hand.
Hi, I had a question. What I know that there are some patients who are afraid to even talk to their doctor about the fact that they want to quit smoking because they're afraid their insurance premiums are going to jump 50%. What sort of help could they offer them, or if they suspect it, so that if they're worried about it getting into their chart, or if they're worried the insurance company is going to find out somehow? How do you reach out to people like that?
I love that. Do you mind if I take that, Laria?
Go ahead, Tammy. Yeah.
Yeah. So as a provider, I totally understand that concern. And I'm glad that you brought that up, Michael. I think one of the things that's great about, for example, some of those business cards that the design team has created, and those tear-offs. And so when a provider might suspect it, they can provide those resources for the patient to reach out if they're ready. And I think it's so important for a doctor, no matter, or a provider, no matter, if they have 100% certainty that the person is smoking, just to state the statement. It's like, smoking is one of the worst things you could do for your health, if, just speaking in general terms. And, but the concern you bring up is so real. And I hope that some of these resources can be not just used by providers, but they could be put out in the waiting rooms and hung up in the billboard or the bulletin boards, and be set out in patient areas, so people can just grab them and use them.
Yeah, we actually had in the last meeting someone who mentioned that the patients really, really liked the quit line posters with the little tear off tabs for the numbers, because I think it was really patient initiated. So they didn't have to have any conversation with their provider. They could just walk up to the poster, take the number, put it in their pocket or wallet, and walk away, and hopefully have that resource available to them. So we didn't have a consistent access to those posters. And so that's why we created our own, and they're now available on the website. But we try to definitely create opportunities that are more patient initiated in that way. So it's not just based on that conversation with their provider.
Okay, thanks.
Yeah. Oh, go ahead, Tammy. I see a question from Miriam in the chat. Thank you, Miriam, for asking this. This is something that is on our list and we're working on developing. And we'd love to continue to collaborate with you as well to hopefully put together a package for that. Great American Smokeout, because I think that's such a great event that happens.
Yes. And what I think is so cool is that we don't try to reinvent the wheel. The American Cancer Association actually has tons of amazing resources that we try to disseminate to other people as well. And so I put the link there in case people are wondering what we're talking about. But I think it's also a very, very cool time to bring focus to tobacco, because there's so much happening in the world right now, but to bring focus on tobacco. And we think that we learn and see how other people promote tobacco cessation, and we hope that we can be the group that brings the best practices to people in the state of Michigan, because we think Michiganders deserve the best. Thank you for bringing that up.
Yeah, that's a really good point too. That isn't currently in our online resource library, a card for they do have like a toolkit, posters and things like that you can print. So I'll make sure we get that added in, so that's available to people through that as well.
Other questions? So please feel free. You all know how to reach out to us. You know, we originally wanted to have some breakout groups, which I don't think we actually need to do. So I'm going to have Sarah move past those slides, and then maybe what we can do, we can end a little bit early, but have people have a chance to kind of look through these resources and email us if they have any questions. But one of the last things we want to do before we end is have Marika, who's our project manager, give a little sneak peek on some new projects or new project that HBOM is working on that we think will be very, might be interesting and exciting to your groups as well. So take it away.
Great. I think I have control now. Hi, everybody. Thanks so much for sticking with us in this meeting. We're really excited to have you all here. So I just want to take the last few minutes, like Tammy said, to quickly share about a new collaborative program we are starting called Healthy Eating Jumpstart. This is just a quick sneak peek of a project HBOM is preparing to launch in collaboration with MCT2D, the Diabetes Collaborative, and then MShield, the Social Determinants of Health Collaborative. So this program is focused on healthy eating in type 2 diabetes. And we know this type of initiative can be useful to countless of other patient populations, or maybe can help you generate exciting new ideas around your work. So either way, please reach out to the HBOM team if something like this program or anything else you might think of sounds like it would be a good fit with your work. Let's see. Okay, there we go. So type 2 diabetes, just kind of orient you to the program, is disproportionately impacts populations with low income or with disabilities. And then these individuals also experience worse food insecurity for a variety of reasons, including income or transportation. And then in type 2 diabetes, this food insecurity can make A1C control more challenging, which can result in long-term complications and poor health in general. And so we want to kind of counter that by increasing access to healthy foods. We hope to jumpstart patients on a better path to health. And so just briefly, the program that we've developed as a result is designed to support individuals with type 2 diabetes who experience food insecurity or are low income in accessing healthy foods by using grocery delivery, and then to promote a healthy diet and better diabetes outcomes. The program is a 3-month-long jumpstart with grocery delivery of healthy foods paired with 12 weeks of educational materials on low-carb eating, including nutrition guides, recipes, tips and tricks related to healthy eating. And we're just really excited to kind of share this program with you and keep working on new initiatives to help more Michiganders be healthy. And so, if anything about this work is inspiring any new ideas, please connect with our team. This is what we want to do. We love, brainstorming and coming up with new ways and innovative ideas on how we can help others be healthy. So that's all I have for you.
Thank you so much, Marika, for that awesome sneak peek. I want to say thank you all for joining us today. We value your feedback, and you will receive a Qualtrics link. I think it might be in the chat. I'm going to double check and open it. If someone could, yes. So before you leave this meeting, even right now, go ahead and please fill that out. We want to make sure these meetings are meeting your needs and that we and our organization is meeting your needs. And so please fill that out. Let us know. I want to end by saying that we know that we don't have all the answers. We know that the answers are among our patients, in the communities, and in your experiences. And so thank you all for being here today. Thank you for sharing your ideas, your questions. We look forward to staying in touch with you. Have a great day, and we look forward to talking to you soon. Bye.
Tammy, do we want to stay on in case anyone has any additional questions?
Yes.
Okay.